Okay, so this is the second center learn we're going to do, and I just want to start off with a quick review of the tiered paramedic system that we're starting, called the lead paramedic system, and it's technically in effect right now. And those of you who weren't at training the other night that got a pretty detailed synopsis of what's going on, I'm just going to give a quick overview. It's not going to be too detailed, but you will get the complete outline emailed out, and it will be in a PDF that you can reference that has all the different types of information that you might have questions about. But this is just the basic overview of what you have to know, and it's really just what each level has a scope of. Everyone that's already a paramedic here has already worked as a paramedic is going to be a level 2 unless you've been talked to by me. Otherwise, any new paramedic that comes in will be a level 1, and then there are just 2 lead paramedics at this time down here, but of course everyone has the ability, once they read that outline on how to get to level 3. It's a very difficult process, but that's just the best we could do with the skills that we're looking to add to those to that level 3 level. It's important to know that every level can do every skill if that highest level is on the scene. So don't think that a level 1 can't give certain meds, because if there's a level 3 there, they can. A level 2 can also do the skills if a level 3 is there. So here we see that a level 1 is a probationary paramedic. They can only act as a paramedic if another upper tiered paramedic is on the scene, which is a level 2 or a level 3. And if they're not there, they're just an advanced EMT, unless there's like an immediate life-threatening intervention that has to be performed. So that's just the basics of it. And the additional medications here that the lead paramedics have are going to be that metoprolol, solumedrol, and famotidine. And there were some questions asked at training. I know it's confusing, and I know you might not agree with it, but as of now, you cannot call med control for those extra medications. So it has to be level 3 on the scene to give solumedrol, metoprolol, or famotidine. You cannot call med control if you're a sole level 2 on the scene. So this training's going to be about use of Etomidate. We've carried it as an Ozaki County medication. It's not a specific Mequon Fire Department medication, and it seems like every time I bring it up, there's a couple questions about it and maybe some misunderstandings of when to use it and how it works. So I'm just going to do a quick review on it. There's also been some cases I've reviewed recently that have indicated uses for it, and it wasn't used, and I wasn't there to know exactly what the scenario was, but I just want to give it a blanket overview so everyone is aware of when it can and should be used. So here's the overall profile of it. It's an interesting medication because it's the only medication that puts you pretty much completely to sleep. If you technically give a high enough dose of Etomidate, your EEG waveform of your brain will actually go completely flat. You'll go completely to sleep till you have no brain activity. It's pretty interesting. So it's technically a hypnotic and anesthetic, general anesthetic for induction, but its exact action of how it works is completely unknown, but it has like a GABA-like effect. And remember, benzodiazepines are the GABA group of drugs, so it has those types of effects in regards to sedation. The advantage to it is it has an immediate onset, so as soon as you push it, that dose that you push gets to the brain, it starts working. And it only lasts for about 5 minutes if you give that normal weight-based dose, but that's going to be dose dependent, meaning if you give somebody 35 milligrams of Etomidate, it's going to last longer than 5 minutes because it's dependent on its half-life. The other advantage to it is it's extremely hemodynamically stable. It maintains blood pressure and heart rate. So for shocky patients or patients in dysrhythmias when you're cardioverting, it's the go-to drug. It also maintains the respiratory drive. People can have short periods of apnea on it, but overall the respiratory drive remains completely intact. The person continues to breathe even though they're going to be asleep and unresponsive. And then, of course, the advantageous thing for us is it removes all the airway reflexes so we can intubate. This is different than ketamine, where the person looks like they're awake but they're out because their eyes are open, they're just staring, and they have their airway reflexes. This one, they're going to go to sleep and their airway reflexes go away, but they're not paralyzed and they still have a good respiratory drive. So it's indicated in Ozaki County for cardioversion and facilitated intubation. Facilitated intubation is when you intubate someone who requires intubation, but you couldn't otherwise intubate them without the use of a medication. That's different than RSI, which is when you're using a paralytic to force intubation on someone. It's not to be used in patients that are under the age of 10 years old, and that's just because there hasn't been studies to establish the safety of it. You want to use caution when the patient's suspected to be septic, and that's septic shock, not just regular sepsis, and that's because it has some adrenal suppression with it, and that can affect their outcome and their recovery from sepsis. You also don't want to redose it for that reason, so there's no such thing as an etomidate drip. There's no such thing as putting them down with etomidate, tubing them, and then resedating them with etomidate. You always move to a benzo or some other sedative after the use of etomidate. For those kids that are under 10 years old, the preferred drug for these types of things is going to be Valium, and the pediatric dose of Valium in Ozaukee County is 0.2 milligrams per kilogram, 0.2 per kilo for kids, and that's going to be for intubation or cardioversion or whatever the case may be under 10 years old. So the etomidate dosing, as listed in Ozaukee County guidelines, is 0.2 to 0.3 per kilo. 10 milligrams is often effective for cardioversion because you're just giving you're putting them down, you give them a quick shock, and then they're going to come right back. 10 milligrams usually does the trick. Now it's important to remember that etomidate puts people to sleep, and it's a powerful anesthetic, and a general anesthetic, so it's going to be a general amnesic, so it's going to be keep them from forgetting what happened, so they're going to experience the pain. So if you put someone out with etomidate and you poke them with a needle, you're going to see their heart rate go up, you're going to see them have physiological signs of pain, but when they come out of it, they're not going to remember that they experienced it. So that's how it differs from ketamine also, where ketamine is the analgesic, where they're actually not even feeling the pain. 20 milligrams is your good effective dose for intubation. So that's going to be your 0.2 per kilo range. The 0.3 is actually a very high dose. I would try and stay away from that. The 0.1 per kilo would be good for the cardioversion. It's very important when you give the etomidate that you anticipate the person's going to be out and they could have those short periods of apnea. So apply some oxygen. Always monitor end tidal when you're going to sedate someone with etomidate, and push it extremely slow. Always push etomidate slow, over 60 seconds. If you push it fast, it's not such a big a deal when you're going for cardioversion, but if you're going to intubate somebody and you push it fast, they can get trismus in their jaw, and then obviously that defeats the purpose of trying to intubate the person. So make sure you push it slow. So cardioversion, obviously, if time allows and it's advantageous to establish IV access and administer a sedative, then etomidate should be your preferred drug unless there's some other reason why you cannot administer etomidate. And then obviously you can use a sedative like a benzodiazepine. You can also use an analgesic only. So these are going to be those patients that need to be cardioverted, but they're somewhat stable where you can get the line, so on and so forth. If you walk in and someone's in VTAC and they look poor, you're obviously going to shock them right away without any sedation. So establish that IV and choose to give etomidate. And again, the reasons why we're giving it for cardioversion as a sedative is because it's got that short duration, so as soon as it wears off in a couple minutes, they're going to come back to how they were. It's extremely hemodynamically stable, so a person who's already hypotensive and crashing, you don't want to give them 5 milligrams of Versed to sedate them. It's also going to be extremely rapid acting, so when you push it, it goes right away. There's no waiting time like there can be with Versed for the onset. And then also Versed's going to have a lot of respiratory depression. So to obtain the same amount of sedation with Versed that you can with etomidate, the person's probably going to be breathing, very slow, probably 6 to 8 times a minute, and it's going to last for about 20 minutes, 20 to 30 minutes. So that's another problem you deal yourself with after getting them out of their dysrhythmia. So here we go, rapid onset, short duration. It's got a very deep sedation, has the amnesia, they're not going to remember the shock, extremely stable, and it keeps those respiratory drives intact. So for intubation, again, it's the preferred drug for intubation because if you were to obtain the same amount of sedation with a benzodiazepine or even mixing a benzo with a narcotic, which we have to call for, you're going to have apnea. With etomidate, the person's still going to be breathing, but they're going to lose that airway reflex. So That's why it's preferred for facilitating the intubation. Also, it's short acting, so if you're not able to successfully intubate the patient, you only have a few minutes of that person being unconscious. Even though they're still breathing, at least they're going to come back to their previous state of consciousness if they were. Obviously, if someone's conscious and you're choosing to electively intubate them, you got to make sure you're justified there. There should be only certain cases where someone's conscious and you're putting them down to intubate them, like airway burns, probably severe respiratory stress where they still have some mental ability, circumferential chest burns or neck burns that you're worried about the airway management, or anaphylaxis where the person's upper airway is rapidly swelling and you want to be proactive and get that airway secured. Anything else, the person's probably going to be unconscious anyway. You're just administering the etomidate to get them into a deeper level of sedation so you can successfully intubate the patient. So the process for this is get your IV access, obviously, since we have to give it IV. It's a standing order medication, so you're going to pre-oxygenate the patient, make sure you get as much oxygen on board as possible, just in case they have any apneic pauses. Then you're going to choose to pre-medicate about a minute before the etomidate, and the pre-medication drugs we can use would probably be most likely lidocaine for the head injury. That's 0.5 to 1 per kilo, given slow, and you're going to make sure they're on the cardiac monitor for that. You don't want any ectopy created from that. And if they're elderly, make sure you reduce that dose in half and stick with that 0.5 per kilo. That's for head injury patients. And then what that does is that blunts that increase in ICP when you put the laryngoscope in the patient's mouth. Atropine should be given for pediatric patients always because they have an increased vagal tone and they can get extremely bradycardic during the intubation attempt. And we all know that when pediatrics' heart rates drop extremely low, their cardiac output goes absolutely gone, which is why you do CPR on kids that have a heart rate below 60. So you need to pre-medicate with the atropine, the pediatric atropine dose, about a minute prior to the intubation attempt. And also, you could also give some fentanyl to any type of patient you're going to intubate prior, probably a lower dose. And what that is, because etomidate's not an analgesic, when you go to intubate, they can still feel that pain. They still have those physiological aspects of pain, even though they're not going to remember it. They don't have the airway reflex. It's still painful to be intubated. So if you take away that pain, it can help them not fight you as much while you're intubating. So you're going to induce the etomidate. You're going to push it again slow, your dose, it's immediate onset. Once it all goes on, give it a couple more seconds and you should be good to go. And then you're going to intubate the patient, confirm your tube multiple ways, so end tidal lung sounds, epigastric sounds, humidity in the tube, and compliant ventilations. And then you're going to want to do some post-intubation sedation with a benzodiazepine of your choice. And that's because that etomidate is going to wear off, and we don't redose etomidate. So you got to give a benzo afterwards to keep them sedated. It may also be advantageous for you to do a little bit of upper extremity physical restraints too, just in case they're still moving around. Because remember, we're not paralyzing these people, so they're still going to be able to move around. So if they're a respiratory patient and they're in respiratory failure and they're pretty much giving up, sometimes after you intubate the patient, they're just so exhausted to move that they're just going to breathe on the tube with you helping them. They're not going to fight you much at all. So here's a quick scenario. You have a 27-year-old male patient who complains of palpitations and chest pains. The patient appears anxious upon arrival in your initial observations. You apply the cardiac monitor, and you show a narrow complex tachycardia at 190 beats a minute, and there's no visible P-wave morphologies. The rate does not vary at all with the patient's movements, and vital signs are 110/50, heart rate of 190, respirations at 24, SpO2 of 97 on room airs. So a relatively stable patient with the exception of his symptoms. So his symptoms indicate that that's a dysrhythmia that needs to be managed. It's a 190, that's pretty high. No P-waves, it's going to be pathologic. So consider all those things. So you get IV access, administer adenosine 6, 12, and 12 series. You have no conversion after all those. You're still 15 minutes from your closest hospital, and you haven't even loaded the patient in the ambulance yet. You're still on scene. So quick, just pause the lecture and develop your own treatment plan in your head here, and then when you're ready to review it, just restart the video. So I'll give you a second to pause here. Okay, so what I was getting at, what I think is the most appropriate treatment for this patient is he's obviously of age for Etomidate use, and even though he's not unstable, you're still a long way away and the patient's still experiencing the symptoms. He's been refractory to all of those medications. So one of your treatment plans could have obviously been to try other treatments like amiodarone or call for cardizem for the SVT as an adjunct treatment, or even metoprolol if you had a lead paramedic there. So those are some obvious interventions, but if you're already giving that patient all those medications, sometimes it's just best to go to the cardio version, especially if it's a wide complex tachycardia. This was a narrow one, but wide complex tachycardias that are stable can easily and quickly deteriorate into unstable or into VFib, and the patient can go into arrest. So always be ahead of the game and try and cardiovert if they're not, if their dysrhythmia is refractory to your initial interventions. So give your 10 milligrams for the cardioversion, very slow IV push. As soon as he goes out, put him on some oxygen, check his end tidal, sync your monitor, confirm you got flagging on the QRS, charge and cardiovert at 100 joules. Hopefully you get conversion, and then just observe, reassess, take a blood pressure, and he should be out of it in 2 or 3 minutes and back to conscious. He probably won't remember much of what happened, so be prepared for that. So here's your second scenario. You arrive on the scene for a 40-year-old male who was at a holiday party and fell down the stairs onto a concrete basement floor about 1 flight of stairs. Patient is unresponsive when you arrive and smells of alcohol. Patient has sluggish but responsive pupils at 5 milliliters. That's on both sides, so they are reactive. Patient has vital signs of 180 at over 100, heart rate of 60, respiration is 26, and his pulse ox is 90 on room air. Blood sugar is normal or a little elevated at 170 milligrams a deciliter. The patient has a large contusion to the back of the head and small drop of blood in the left ear. So real quick again, read the scenario, develop a treatment plan, pause the video, and then we'll review it at the end here. So I'll give you a second to pause. Okay, so obviously this patient's unresponsive, so we can't clear the C-spine, so you need to take C-spine precautions immediately based on the mechanism and him not being able to answer your questions to clear the C-spine. So do an assessment, see if you feel any step-offs or deformities, and then obviously take your C-spine precautions. Establish your IV access, and then you're going to obviously need to intubate this patient. You had a borderline SpO2, unresponsive, not able to protect his own airway, so you're going to check for a gag reflex. If the patient has an absent gag reflex, you're going to intubate anyway. If he has an intact gag reflex, then you need to medicate to intubate the patient. So this patient is grounds for pre-medication with lidocaine, so administer your pre-medicated lidocaine, and then you want to pre-oxygenate the patient. This patient would probably get positive pressure ventilation with a BVM. You want to, obviously, MPAs are okay if the patient has an intact gag reflex, but that contraindication with head injuries, just be aware of it. Really, it's not really a true thing unless the patient has like a true Lefort 3 fracture at the base of the skull, and you'd know that with really serious raccoon eyes and battle signs and so on and so forth. So with just a bump on the head, that could be an internal bleed. I don't know if you're worried about injury from MPA insertion. Then you're going to give 20 milligrams of etomidate. Make sure you give it very slow because you are intubating now, and you don't want that locked jaw from a rapid push of etomidate. Intubate, confirm your tube placement again. Then you got to do your post-intubation sedation with Versed or a benzodiazepine. You're going to redose as needed as long as you maintain blood pressure. Obviously, you're not worried about respiratory drive because you already have intubated your breathing form. And this patient requires a trauma center transport. That's another consideration. If we're up here in Mequon and we're transporting this patient to the trauma center, that's a long time. We're going to have that patient in the ambulance probably 15 to 20 minutes. So you want to be ahead of the game to take their airway because you don't want to be in the back of the ambulance alone or with one other person when you have to do it if they start to vomit and can't protect their own airway.